All right. So we have a 65-year-old gentleman who presents for altered mental status. And I'll go a little bit further and complete that, the left side of the screen. So, like I said, 65-year-old gentleman. 3 days prior to admission, he started having upper respiratory tract symptoms, including cough and congestion. At that time, the patient was otherwise in his usual state of health. Of note, and this is going to be important for later, he does have alcohol use disorder, and he normally drinks about 10 to 15 pints of beer per day. But the day prior to admission, he only had 3 pints of beer. He stopped eating, but was still communicative with his wife. And then on the morning of admission, he was minimally verbal, he was agitated, he was confused, he was oriented to self, but not oriented to anything else. And he was found by his wife in EMS laying in his bed and having urinated on himself. At that time, he did not have any respiratory difficulty or anything like that. Of note, he had a similar episode around 10 years prior to admission, and he was admitted for alcohol withdrawal. He abstained from alcohol for about 6 months after that admission. However, he then started drinking again. So he was seen in the ED. He was given fluids. He was started on alcohol withdrawal management, and labs were drawn. And he was, and then he was admitted. So the only other thing in his past medical history other than his alcohol use disorder is hypothyroidism. He has not had any prior surgeries. In terms of medications, let me see what he had. He was on levothyroxine, extended release metoprolol, quetiapine, gabapentin, and folic acid. In terms of his family history, there is an extensive alcohol use disorder history in his family. Multiple members of his family had died from complications from alcohol use disorder. And in terms of his social history, he lives at home with his wife, who is his primary caretaker. He also has a son who helps with care as well. And then in terms of other health-related behaviors, he doesn't smoke, he doesn't use any other drugs except for the alcohol. And he has no known allergies. I think with that, I'll stop there.
All right, thank you so much, Drew. This is a phenomenal start to this case. I think really what my mind is primarily contending with right now is what to do with the cough and congestion as it relates to the altered mental status, right? Acute encephalopathy seems to be the predominant clinical syndrome and is the center of gravity of this case. And we could make an excellent case for any of the categories of altered mental status in our MIST framework, right? Metabolic abnormalities that this gentleman could have could be related to his underlying alcohol use disorder and hepatic dysfunction. And then also in somebody who's drinking predominantly alcohol and high beer intake, but potentially not many other substrates. You also wonder, is there a possibility of coexisting hyponatremia here as well that could be increasing his risk for or symptoms of an acute encephalopathy, specifically through something like beer potomania or a tea and toast diet. From an infectious standpoint, right, we have to grapple with whether or not the acute encephalopathy, cough, and congestion is potentially related to an underlying community-acquired pneumonia, or is there potentially a risk of a more indolent, protracted pulmonary complication of alcohol use disorder and aspiration events, something like a pulmonary abscess? But that is going to be something that we'll only contend with at the exclusion of something like a community-acquired pneumonia. Structural lesions that could possibly be at play here, right? Individuals who drink heavily are at increased risk of falls. And if there is coexisting liver dysfunction, there may be an increased risk for bleeding as well. And so a structural lesion is also not necessarily off the table here. And then certainly toxin effects, right? We see that this is somebody who has continued to drink heavily, so there could be some intoxication at play. But as Drew mentioned, there was an abrupt decline in this individual's alcohol intake, and the team very astutely empirically initiated alcohol withdrawal treatment, even though this individual had continued to drink, because again, alcohol withdrawal is a disease of relative alcohol intake rather than absolute alcohol intake. So individuals can withdraw with alcohol in their system, and they can also withdraw while they are continuing to drink if there has been an abrupt change in that amount. And so I think at this point in time, right, we really have to work to define the problem. Is this an acute encephalopathy case alone, or are dealing with pulmonary disease alongside acute encephalopathy? The differential for the encephalopathy doesn't necessarily shift drastically, but the probabilities of the different categories within each of those buckets does change, right? Pulmonary or something like a pneumonia plus acute encephalopathy, we start to worry about complications of sepsis, complications of bacteremia from community-acquired pneumonia, and then the dreaded syndrome where individuals could have strep pneumonia that then potentially leads to a bacterial meningitis as well. So I think at this point, it's really like, how do we define this problem space better, recognizing that all of the acute encephalopathy or MIST framework is potentially at play here, and we can draw lines to the M, the I, the S, and the T, all of which I think are still at play. But I'm curious, Sharmise, what are you making of some of the other data that we got from the background?
Yeah, that was really beautiful, Jack. And what my mind is doing, thinking, alcohol use is a prominent feature of the presentations. And another way I'm thinking about it is like kind of the overlap of alcohol use and altered mental status. As you mentioned, like withdrawal, especially like delirium tremens, is a good thing to think about. That kind of starts like 3 days after. Again, I think even with the relative decrease, you can see that, altered sensorium is a big part of that with autonomic dysfunction. The other way is seizures. And so kind of thinking about like, hey, asking the wife for more histories, like any evidence of the fact that we're seeing with the altered sensorium is related to alcohol use related seizure. And then the other friends to think about here and not forget is thiamine. And so thinking about someone who's if he's been binging alcohol and thiamine deficiency from Wernicke to Korsakoff, Wernicke for sure can have usually you have also other features like from the ophthalmoplegia to ataxia, but again, altered sensorium can be seen there. So like I think exam would be really, really helpful. And as Jack also alluded to, thinking about what else, like alcoholic hepatitis is another thing to think about. So, it might be related to alcohol use, it might not be, but again, with that heavy of use, it's worth, as they did, definitely treat for alcohol withdrawal and do some more investigation, and hopefully with exam and lab we can make some progress with what is going on with these patients. In terms of the past history, it would be informative to know, especially if the patient has been taking their levothyroxine. However, I think if it might be contributing. As of now, I don't think it might be the leading issue here. So I'm curious to hear more information. Drew?
I like it. This is truly a all of the diseases trying to figure out which one kind of patient. But there is one disease that will be highlighted in this, and let's go to the physical exam. So vitals, temperature of 36.8 degrees Celsius, heart rate of 129, respiratory rate of 21, blood pressure of 152/80, and saturating 100% on 2 liters nasal cannula oxygen. So when you go down to see him, he's resting in the hospital bed, but he's mildly agitated. For his HENT exam, the main thing that's notable is that his oral mucosa is dry and his dentition is poor. Cardiovascular-wise, he's tachycardic, but with a regular rhythm and no murmurs, rubs, or gallops. Pulmonary-wise, normal. His abdomen is protuberant, but soft, non-tender, with normal bowel sounds, no hepatosplenomegaly, and at least I was not able to appreciate any ascites or any fluid wave or anything like that. Neuro-wise, he is alert, but he's not oriented in really any domains. He was not talking at this point, and he was not able to follow any commands at all. And then in his extremities and skin, he does not have any edema. His pulses were normal. His skin was warm and dry, but he just looked disheveled. And then let me give you his CBC and his CMP, because that will allow for a lot of talking. So white count, 16. Hemoglobin of 15.2. Platelets of 157. And then for his CMP, sodium, 120. Potassium of 3.7. Actually, give me a second. Let me just get that. Let me just. Chloride of 81. Bicarbonate of 24. BUN of 4. Creatinine of 0.36. Glucose of 108. Calcium of 8.6. Magnesium of 1.8. Or sorry, 1.5, I meant, not 1.8. Phosphorus of 2.3. And then for the rest of his liver, AST of 62, ALT of 17, alk-phos of 55, total bilirubin of 0.9, albumin of 3.6, and total protein of 7.2. And I'm going to leave it there for now.
Drew, just masterful case presentation. Thank you so, so much. It's always a good day on a VMR when Jack Penner gets to talk about hyponatremia. So thank you for this. Just kind of starting from the vital signs, and then I'll be fast and pass the mic to Jack. The one thing that caught my eyes is the fact that he's on 2-liter nasal cannula. That's something at the bedside that I would just turn it off to see if actually patient is hypoxemic or not, and to figure out if that is also a problem that I need to put on my list of things to think about, maybe lower than hyponatremia, but if the patient is truly hypoxemic or not, especially with someone who has a leukocytosis, although any type of stress reaction can cause leukocytosis, but leukocytosis plus hypoxemia at risk of aspiration, definitely infection is something you want to think about. When you see a patient with a heart rate in the 120s and an exam that appears dry, you want to give them fluid. With patients with alcohol use disorder, wait. It's okay to wait till a patient is stable to get that basic metabolic panel. And my disclaimer for it before we pass the mic to Jack to talk us through the hyponatremia and the labs a little bit more is that patients with alcohol use disorder have multiple reasons to be hyponatremic, and they're at risk of overcorrection. And alcohol use in itself is a risk factor for developing demyelinating syndrome. So this is a patient that you want to be careful anyways. And they have competing factors as to why they're hyponatremic. So be careful with sodium, with fluids, in someone with alcohol use disorder. Jack, take us away.
I think that's such a phenomenal management point, Charmaine. I appreciate you highlighting that so much, because there is oftentimes this reflexive tachycardia. All of these factors make us want to give fluids. But as Charmaine was saying, this is one of the scenarios where there is an enormous risk of overcorrection, and that's via two possible mechanisms. The first is via the mechanism of, if we are dealing with a very low urinosm, so a hypoosmolar hyponatremia with a low urinosm, that could potentially put us in the tea and toast beer podomania category. Or we're dealing with a hypovolemic hyponatremia. And both scenarios, for different reasons, are at risk of very rapid overcorrection, right? So if we now zoom out and say, okay, well, what is the etiology of this gentleman's hyponatremia, which is certainly a part of, but likely not the sole driver of his acute encephalopathy, right? We can presume that we're in the hypoosmolar hyponatremia bucket, right? We don't see levels of hyperglycemia that would give that we might be dealing with. The alcohol could cause some degree of hyperosmolar hyponatremia, but likely not going to bring someone down to 120. So for all intents and purposes, we can presume that we're in the hypoosmolar hyponatremia side of things. And from here, then, what we have to ask ourselves is question number one: is ADH on or off? In most cases that you see of hyponatremia, you will have a high ADH state. That's from hypovolemia or something like SI-ADH. But this gentleman has risk factors for actually having a low ADH state, given his heavy alcohol use and very high volume intake with 10 to 15 beers a day. The way that we end up understanding the ADH status in the body is by looking to the urinosms. If the urinosms are very low, that means that the urine is very dilute, which puts us in the beer podomania or primary polydipsia category, the former being likely in this gentleman. The reason for that is that there is such a high free water intake in the very solid, poor fluid that somebody drinks when they consume heavy amounts of beer, that the body is trying its best to clear free water and normalize the sodium level. But the kidneys need solute and protein to be able to clear free water effectively. So someone who's only consuming high amounts of beer but not a large amount of solute via, for example, other electrolytes and protein intake, the body can't necessarily clear free water fast enough, and so they become hyponatremic. When we give that person 2 liters of normal saline or 3 liters of normal saline, they get an enormous salt load, right? They get lots and lots of sodium, lots of chloride, and other electrolytes. And the kidneys then, to clear that solute load, right, will end up clearing lots of free water along the way because their kidneys are trying to maximally dilute the urine. So you may give somebody 3 liters of fluid, but they can clear solute in that fluid with maybe 6 or 7 liters of urine output. When we give them a little bit of normal saline and they make a lot of urine that's very dilute, the sodium will rapidly overcorrect. So there's 2 ways that we can find out the answer of ADH status. And that is, one, by looking at the urinosums, but that can take some time to come back, and we may need to make management decisions up front. So the other way that you can get a quick calculation of what someone's urinosum might be is by looking at the urine specific gravity. If the urine specific gravity is very, very low, right, like 1.00 something, then the likelihood that we're in the tea and toast or beer potamina category goes up dramatically, because it's a sign that this person's urine is very, very dilute. So that's how we can potentially explore the beer potamania side of things. But the other hypothesis is that ADH is actually very high in this case, because this gentleman is profoundly hypovolemic based off of the findings that we have on the physical exam. And in that case, right, hypovolemic hyponatremia, ADH is very high, and so is aldosterone, right, which is going to lead us to have a low urine sodium. So the urinosum and the urine sodium are going to be our 2 key tests here to help us make progress. But a large fluid bolus in somebody with hypovolemic hyponatremia can also lead to rapid overcorrection. And this is because when we volume resuscitate somebody, we expand their intravascular plasma volume. Those carotid baroreceptors are like, hey, things are looking better. I can turn ADH off. I don't need to hang to volume because I'm getting volume resuscitated. And then when those baroreceptors lead to ADH getting shut off, the body will clear free water very, very rapidly, and we can also see overcorrection. So exactly as Charmaine was saying, this is one of the cases where it's worthwhile to be cautious with volume resuscitation up front. Wait to get those urine studies. If we're dealing with the beer potamania and tea and toast side of things, we have to watch this correct slowly and be very diligent with how this happens. If we're in a very high ADH and high aldosterone state, we can think about giving DDAVP up front, which basically clamps the rate that this individual can overcorrect, right? We said that volume resuscitation will lead to AD shutting off, but we can give some ADH back in the form of DDAVP, which can help slow down the rate of correction. So those are some management decisions that we might be looking at as we go down the diagnostic algorithm. Again, gentle with fluid resuscitation, not committing to a high amount of volume until we have those urine studies back. And if the urine studies reflect a hypovolemic hyponatremia, high urinosum, low urine sodium, then we might think about giving DDAVP, because this gentleman's risk of overcorrection and complications with overcorrection is very high.
Well, whoops, they gave a liter of normal saline in the ED. So, but let me give you those urine studies, and I will tell you the tale of what happened to this gentleman. So, because his sodium was so low, and because, as you astutely mentioned, that risk of overcorrection, he was actually admitted to the ICU, which is where I saw this patient. So, his UA, he had cloudy urine with a specific gravity of 1.007. Protein was negative, glucose was negative. He had 15 milligrams per deciliter of ketones, negative for blood, nitrite positive, leukocyte esterase negative. And when they did the microscopy, he had 1 white blood cell per high power field, 1 epithelial cell per high power field, 4+ bacteria, and the urine culture eventually came back with Enterococcus faecalis, actually. But his UDS was also negative, and his blood alcohol level was also negative. All right. So now for sodium labs. Serum osm, 267, which is low. Urine osm, 223, which is low. Urine sodium, 55, which is normal. And then in terms of other things that needed to be ruled out, cortisol was normal at 27.4, although that was not collected at 8 a.m. He already has known hypothyroidism, but his free T4 was 1.2, which is normal. The studies were before saline, Emery. And then just to complete his encephalopathy workup, his ammonia was fine at 11. And his lactate was normal as well at 1.2. And then he got blood cultures, which were negative. And flu, COVID, RSV were also negative. And let me see if he got a chest x-ray on admission. He did. And it didn't show anything, any major consolidations. And his CT head was negative.
All right, I will talk through some of the UA and how it relates back to this patient's leukocytosis, and then we'll kick it to Charmaine to take us through the other parts of the urine sodium and all of that goodness. In terms of what the progress that we can make from the patient's urinalysis, the specific gravity of 1.007 again is lower than somebody who is profoundly hypovolemic and not necessarily rock bottom, which is reflected by the moderately low urine osms that we see. But what's also interesting here is that it seems like this gentleman, that we potentially have an explanation for this gentleman's sort of systemic inflammatory syndrome that he came in with alongside this profound hyponatremia. I would say the urine culture growing E. fecalis is potentially something that we might say, oh, this person has a urinary tract infection. But one of the things that's interesting is that we don't see profound degree of pyuria, and we don't see a very prominent symptom burden that localizes to the genitourinary tract. Our ability to at least make progress on that is limited by this gentleman's encephalopathy. But I think that this is a tough case where we have to sort of ask ourselves, do we feel like there is a urinary tract infection that's contributing to this acute encephalopathy? Or do we think this is just asymptomatic bacteriuria in an elderly gentleman? Both hypotheses are probable here. And I think that if you were to sample 100 clinicians, you would probably see a spread on whether or not somebody gives this person antibiotics. I would just think out loud and say for me that the combination of this gentleman's degree of illness, the white count of 16,000, and no other clear localizing source of infection makes me feel like we've crossed the threshold to give him antibiotics for a urinary tract infection, recognizing that if there was a clear mental status, we may get more of a history of dysuria, urgency, frequency, and other symptoms here, right? If the white count was normal, and if his mental status rapidly improved with correction of a sodium, right, we may be able to hold off on antibiotics. But I think at this point in time, the consequences of being wrong are probably, or I should say the consequences of not giving antibiotics are probably higher than the consequences of giving at least a dose or two of antibiotics while we see the trajectory of his initial presentation. And so I think in this case, that is sort of where I would think of for the management, given that E. fecalis is a very compatible organism to cause a symptomatic UTI. But more excitingly, the electrolyte abnormalities, I'm going to turn over to you, Charmise.
Well, it's hard to talk about hyponatremia with you here, my friend. That was such an eloquent discussion of the hyponatremia framework. So this was not what I expected. I don't know how you guys feel, but I didn't expect your sodium studies, but let's walk through them. So with the urine osm of, with like the serum osm that is low, then we usually look at our urine osms at 223. We usually then think about like, okay, what is the urine sodium is doing and what aldo is doing. And it's normal, which means like aldo is like, I'm cool. So that category of diseases, we usually think about adrenal insufficiency, but that's what was like the cortisol was. So if the patient was hydrochlorothiazide, SIADH, I wonder if like his underlying hypothyroidism is contributing to that. Because clinically, what I still worry about this patient is that his volume down and he hasn't been eating, so he must be salt down. So I'm still worried about that, even though the urine sodium is like putting me in the category that I'm like, okay, so this is what I would do in reality. I think this patient belongs in the ICU. I'm glad he was admitted to the ICU. And I often think about these causes of sodium kind of like duking each other out, like duking it out, right? Like who is winning at this moment? Is the patient more dry or they have like a salt? Just being such a conceptual learner, which means that at any moment, if we fix one thing, another one would pop out, right? If an ADH is on and then suddenly patient is eulemic and ADH is off, then you're going to start seeing a lot of urine output. So the things to really monitor in this patient in the ICU is the hourly urine output, in addition to like repeating labs Q3, Q4. So I would personally repeat these labs, his sodium labs again. And then kind of like think about the management steps Jack was saying. Jack, any other thoughts on the urine, the sodium studies?
No, I think I could not agree more that it seems like we probably have both mechanisms at play. If there was solely hypovolemia driving this, I agree with you. The urine osms should be much higher, and they're potentially not as low as we might expect with purely beer potomania because of the coexisting hypovolemia. So I'm right there with you.
Yeah, Drew. What did you guys think?
Yeah, so ultimately, at least our diagnosis was beer potomania. We initially didn't really do much of anything. We just, again, watched his BMPs like every 4 hours just to make sure that he wasn't overcorrecting. He did. His sodium jumped up to like 130 after like 8 hours. So we started him on D5 water, and he was still climbing to like 133. So then we had to give, so we increased the rate of his D5 water, but we ultimately did give him a couple of doses of DDAVP or desmopressin. Eventually he was at the point where his sodium corrected to a point where we weren't worried about symptomatic hyponatremia anymore. And eventually he got out of the ICU. He is still admitted, but more for, but his acute problem is gone now.
And he's no longer altered?
No, he is still altered. Well, he also was, it's hard to say for sure what his mental status was prior to this acute exacerbation of his encephalopathy. But there was an element of at least dementia / like Korsakoff syndrome. And yes, he did get IV thiamine.
Yeah, great point, Anne-Marie. That was my thought exactly, is that this is someone I would also be giving high dose IV thiamine.
He got thiamine, and he got thiamine, folates, all the things. It was a little bit complex because oh yeah, and then antibiotics, he got a dose of ceftriaxone in the ER, and he eventually got narrowed to ampicillin. But that's, I think, about to finish. So
And Drew, were the antibiotics, was it for like, we're going to give this for a diagnosis of a UTI, or we're just giving this from sepsis not otherwise specified, and then continued it once the urine culture came back and you had to get instrumented? I'm curious how that sort of discussion played out in someone who's this ill, but with no like clear localizing source up front.
Just based on what the ER had said, they did it just based off of the UA. They didn't necessarily I think because he was so altered, they were concerned, even though he didn't have pyuria, that maybe there was an infection. But the blood cultures came back negative. The urine, I think, to be quite honest, just was bacteriuric without being pyuric. And he did have a urethral stricture, which necessitated a Foley placement by urology. So there was that. So that's why the antibiotics were, oh yeah, Marcia-Fava-Bignami syndrome. That was the other thing that crossed my mind. But I guess he was altered to the point of he probably has it, but we don't necessarily know. Again, on this case, it was the yeah. So yeah, but he still did get thiamine. So yeah.
Thank you so much, Drew. It's always like, so, altered mental status, we see a lot, and it always worth walking through because it's such a common diagnostic pathway for us, and it's complicated. When we see the sodium of 120, we're like, we have a reason, and we fix the sodium and patient continues to be altered. So our jobs are not done. So it was like such a great case. And I'm curious to see how the patient does. We have that's why we have altered mental status 1.0, 2.0, 3.0 is that, as Drew mentioned, once we kind of exhaust our acute causes of altered mental status, then we have to start thinking about either more rare causes or, more like subacute causes that this patient might be suffering from. I thank you so much for sharing. Jack, any other thoughts before we pass the mic to Sammy?
No, it's just Drew. It's great to see you. Thank you for bringing such a great case.
All right, Sammy. Thanks, Drew. That's all you.
All right. Thank you so much, Drew, for this amazing case. I also love hyponatremia. I got my enthusiasm from Jack a long time ago, so thanks for that. So proceeding to the teaching points, we discussed some risks of alcohol use disorder or liver disease. Patients can present with hyponatremia, hypoglycemia, alcoholic steatohepatitis, or decompensation of the liver disease. They are also at increased risk of falls, bleeding, aspiration, infection, nutritional deficiencies, especially thiamine and phosphate, but also consider drug toxicities and withdrawal syndromes. Then Jack overlaid the two syndromes of AMS and cough and congestion, which made him think about community-acquired pneumonia, aspiration pneumonia, plus minus an abscess, especially think about Klebsiella in alcoholics, but also sepsis and maybe consecutive meningitis if there is like bacterial spread. Then we discussed some findings of cirrhosis that increase our pretest probability. For example, if you see a platelet count less than 160,000, that had a likelihood ratio of 7, or presence of ascites, likelihood ratio of 6 for the presence of cirrhosis or portal hypertension. Then Sharmeen walked us through, doesn't matter, you both are masterful. They walked us through that we should be careful with giving fluids in patients with alcohol use disorder because they're at increased risk of overcorrection and osmotic demyelinization syndrome due to low solid intake and hypovolemic hyponatremia, because those are more common in this population. Then Jack walked us through hypoosmolar hyponatremia. It's very important to think about what is ADH doing and what is the RAS system doing. For that, we should get a urine osm and a urine sodium. The urine osm tells us if ADH is on or off, and the urine sodium tells us if aldosterone is on or off. And ADH is only appropriately on if aldosterone is on, or you have an acute stressor, for example, like nausea, vomiting, pain. Another pearl to estimate the urine osm, if you can't wait for the numbers, you can take the specific gravity and multiply it with 30, or you can also just check the color of the urine. If the color is very bright and it's clear, the urine osm will be high, will be low, right? Because the urine is still diluted. So regarding beer potomania, beer has only like carbs, so it will get metabolized into CO2 and water and has no solutes. So what that means for the body needs solutes to excrete free water through the kidneys. And if you don't take enough solutes in, your kidney won't also have enough solutes to excrete the free water, because there's a gradient in the kidney that has to be established to also excrete the free water. So if you lack solutes, you can't excrete the free water. And the last teaching point is that a positive urine culture does not always require treatment. In this case, it certainly did, but we should always consider colonization and not overuse antibiotics. And especially if there's an absence of pyuria, that has a very high negative predictive value of absence of urinary tract infection, and then we shouldn't give antibiotics. So thank you all so much for this amazing half hour, and wish you all a nice afternoon, evening, or morning.
Sammy, I'm just such a big fan of you. That was fantastic. Thank you so much for joining us. And if you're in a country that celebrates Thanksgiving, happy Thanksgiving. We're all very, very grateful for all of you for joining us and making this community so special. I think the VMR is going to be on a break for the next couple of days, but we'll see you very, very soon. Thanks all. Bye.